Oh, great. Well, good morning, everybody. Thank you very much for the invitation to come and speak here, and thank you to the organisers, Joe and the team, and Ian at Ocumel for the invitation. So I was asked to talk to you about the diagnosis and management of ocular melanoma, and I think Sarah may have covered some of this already, and Bertil yesterday may have covered some of it, but I'll go through it from my point of view. So eye tumours can affect any part of the eye and the surrounding tissues. That involves the orbits, the eyelids, the conjunctiva, the layer on the surface of the eye, where we get conjunctivitis. The uveal tract, so the choroid, ciliary body and iris, the retinal pigment epithelium, the retina, and then even the vitreoretinal compartment. So maybe I can use my pointer, yeah. So all the different tissue structures from front to the back of the eye. And in being an ocular oncologist, one of the advantages we have is that we can look into the eye and see most of the tumors, and most of it is pattern recognition, that you look and if the tumor has a certain amount of characteristics, you can be more than 90% sure of what you're dealing with just by looking, and then some of the tests that are done can confirm your impression. So in the UK, ocular oncology is organised, separated between adults and children. In adults, as you've already heard, 4 centres: London, Sheffield, Liverpool and Glasgow. And then for children, there are 2 centres, London and Birmingham. And the equivalent of Ocumel is the Childhood Eye Cancer Trust, who support the families of children with cancer. They don't generally get melanoma, they tend to get different cancers and are managed separately. And all of it is funded through NHS England, the kind of specialised commissioning. So the most common tumour in the eye that we see is a nevus, or a mole. Like you can get moles on the skin, you can get them in the eye. And 10% of the Caucasian population has a mole in their eye, and they arise from melanocytes in the stroma of the choroid. And here's a few pictures of how they look. They're often quite flat, can be slate grey, they can be pigmented. Melanotic just means pigmented, or amelanotic means pale. And here's one that's got some pale bits and also a darker bit. And then these little white flecks are called drusen, which imply that this mole has been there a long time. So when you look in, even though this looks quite large, actually it's got features to say it's been there a long time. And when you do an ultrasound scan, it's only very minimally elevated. So looking in the eye tells us quite a lot. What do we do with moles? Well, we'll take a baseline photograph, we'll do an ultrasound scan, and then periodic observation. So like a mole on the skin doesn't necessarily need any treatment, in the eye as well, you just need somebody to have a look at it. That may be an optician, it may be a ophthalmologist in a general clinic, and then the more suspicious ones get sent up to us. So a lot of what we do is work out what is a suspicious mole compared to a melanoma. And if a mole grows, then generally speaking, it is turning into a melanoma, and then we would treat it as a small melanoma. And we'll go through the treatment. So just to show you an example, here's a patient with 2 moles actually. So this is their left eye. This white disc is the optic nerve. This is the central area where central vision is. There's a little mole here, and then this larger pigmented area. When you take a better look at it, it's here, and it's got a little bit of thickness to it. It's a mole, and we followed it. Ultrasound scan showed an elevation of only 1.5 millimeters. A year after, it looks exactly the same. Ultrasound is staying the same. And then 2 years afterwards, it's still the same. And then 6 years afterwards, you can see it's formed a lump, which is protruding from the surface. And now when you do the ultrasound, you see the typical features of a melanoma. This one has a kind of mushroom shape or a collar stud, but they can also be dome-shaped as well. And so this patient was treated with radiotherapy. All the options were discussed, and the patient had radiotherapy. And this is the tumor responding to radiotherapy. So just as melanomas take a while to develop, they grow slowly, they also respond to radiation slowly. So people often think that as soon as you give the radiation, that's it, they're going to just melt away. But that's not the case. They take time to show a response. And it depends also on the type of radiation that you have. So if you have plaque radiotherapy, they tend to show a response more quickly. With the proton beam, it tends to take a little bit longer. So how often does a nevus change into a melanoma? Well, there was this very old paper from the 1970s that said 1 in 500 would change over a 10-year period, but none of us really believed that. And this was updated in 2005 by Aaron Singh, who is ocular oncologist at the Cleveland Clinic in America. And this is more like it. This is that the annual rate of malignant transformation from a choroidal nevus to a melanoma is about 1 in 8,845. So this is more realistic. People have estimated 1 in 5,000 to 1 in 10,000, and this seems to be a sensible figure looking at all of the evidence. So how do we tell whether a mole is suspicious? How do we tell whether it might even be a melanoma? Well, there's 5 major things that we look at. Thickness more than 2 millimeters when we do an ultrasound. If there's fluid under the retina. If it's symptoms, so things like flashing lights, blurred vision, sometimes floaters as well, those are all indicators that the lesion in the eye is significant. And then orange pigmentation on the surface and how close it is to the optic nerve. Not all melanomas have all of those, but those are how we classify and decide which ones are more likely to become melanomas. So moving on to melanomas then, uveal melanomas are less than 5% of all melanomas. The majority of melanomas, as you all know, occur in the skin. And out of all the melanomas that we see in the eye, choroidal is the largest population. The incidence is about 5 to 10 cases per million of the population, and it's very similar incidence in Europe and the United States compared to Australia and New Zealand. So whereas skin melanoma is very different in Australia and New Zealand, they have much more skin melanoma, and that is, we think, related to higher UV light exposure in Australia and New Zealand. So because there's a similar incidence in Europe compared to Australia, we think that UV light exposure is not a significant factor in the development of uveal melanoma. Males are slightly more affected than females, and overall small numbers, so between 500 to 600 cases a year in the whole of the UK. So this is American data. If we look at the age-adjusted incidence, generally it is a disease of the kind of middle-aged and elderly, but not necessarily. There are cases at the extremes. The oldest that I've treated is 103, and the youngest, until a few years ago, I used to say was 13, but a couple of years ago I had a 1-year-old with a uveal melanoma. So it does occur at the extremes as well. It may be that we're getting better pickup, opticians picking up things more. I think there is a trend to lesions and patients therefore being referred a bit younger than this data. But that's just my own impression rather than anything in the literature. If we look at the incidence per million of the population from 1973 to 1997, it's a relatively horizontal line. And if you, this is for uveal melanoma, but if you did this for skin melanoma, it is an exponential increase. So the diseases are different, even though they share the same name. Not everything that occurs in skin melanoma relates to ocular melanoma. So what are the risk factors for developing melanoma? Well, it's 150 times more common in Caucasians than Africans. I think in my career I've probably had half a dozen or so pure Africans with uveal melanoma, so it does exist. It's very, very rare, but it does exist. Light skin color, blonde hair, blue eyes is the textbook kind of example, but it occurs across the board. Nevus of Ota is a risk factor. That is a condition where one eye usually from birth or early childhood, has excess pigmentation. And those patients are more likely to develop uveal melanoma because they have more melanocytes. So they have more pigmented cells, and therefore they're more likely to develop the uveal melanoma. And then there's another condition where you can get often benign tumors, neurofibromatosis, often on the skin as well. And usually these are benign, as I say. But there is a slightly increased risk of getting uveal melanoma. So each of the centers has seen a few of those cases. I don't think it's a very strong risk factor. Environmental, well, sunlight exposure we think is not significant. Occupation, there's very inconsistent evidence, and that's probably because of the rarity of the disease. There was a study from France that said welders were more likely to get it. There's a very old study from the UK that said judges and teachers were more likely to get uveal melanoma. And so that is a difficulty of teasing it out, because it is a rare disorder, and making these kind of population type analyses is very difficult. So what do they look like? It's a mass that arises from the choroid. It can be dark, like the top left panel, or it can be pale. They have orange pigment, little flecks. This one has got a little bit of hemorrhage as well, so these are orange pigment here. Hopefully that projects okay. And then a little bit of bleeding from it. Big retinal detachment here, which is the fluid. When you do an ultrasound, you see this either a collar stud shape or a dome shape. And then fluorescein angiogram, generally we don't use. This is a dye test where you can look at the circulation of the eye and the circulation of the tumor. We don't generally do this to make a diagnosis, but sometimes we do. So what you can see here is this blood vessel is part of the retinal circulation, and then underneath it, the kind of fuzzy white signal is the circulation within the tumor. So it's so-called double circulation, but as I say, it's rare for us to need that. So how do we treat them? Small ones you can observe. So the example that I can give you is my 102-year-old patient when he had a small melanoma, and I told him and went through the options, and he didn't want treatment. He said, no, I'm 102, I don't want to go through anything. And he changed his mind when he was 103 and came back to me and then had it treated, which was fine. But observation is an option, because some small melanomas can be observed in certain situations. You may have heard about TTT or PDT. So TTT was or is a type of laser treatment that heats up, so kills the tumor by heating it up. And for a while there was a vogue of using it as a first-line treatment in small melanomas. That's no longer the case. What we found was that the surface of the melanoma was treated very well, but the deeper layers weren't treated so well. So they recurred, and not only did they recur, but they could grow outside the eye, and that's a very difficult situation to fix. So that's fallen out of favor as a primary treatment, but it is still used as a second treatment. So if, for example, you have plaque radiotherapy and you need to top up with something, then you can top up with thermotherapy. Or if there's a small recurrence, like a little nodule just growing in an already treated tumor, you can treat that with a bit of laser. PDT, again, has been worked on by our group and Sheffield as well, and others. And that is where you inject a laser-sensitive dye through the bloodstream and then activate the dye to really destroy the tumor in the eye, and using a laser. And that had a lot of promise. We found that in the first year, 80% of small tumors could be controlled, but the control rate dropped off in the second and third years to about 50%. So again, there might be some selected cases that might do okay with that, but it's not a main treatment. The advantage of it was that you could try and spare vision. And so in people who really wanted, they just had a small tumor, very small tumor, and wanted to preserve vision, that was an option. But really that's kind of falling out of favor. I think that will be the future. I think there will be dyes. That was treatment taken from conditions like macular degeneration, because that can grow blood vessels that can be sight-threatening. So the idea was that we use the PDT to treat the tumors and hence treat melanomas, small melanomas, because there would be an effect on the blood vessels and on the tumor cells themselves. We still use it in other tumors in the eye, so blood vessel tumors, for example, we still use quite a lot of PDT. So you may have heard or read about PDT, just to put that into context. Medium melanomas, generally speaking, we will treat with radiotherapy, proton beam or plaque brachytherapy. Compared to the figures that Sarah showed for Liverpool, we probably do a bit more plaque brachytherapy in London. We have notch plaques which can get right up to the optic nerve, which I'll show you in a moment, to treat the more posterior ones, but proton beam also is an option. And we do have a significant number that we send for proton beam where we can't treat with plaque. Surgical resection, again, done less and less commonly now, but it is a possibility. And then TTT was used in medium melanomas, but now really is an adjuvant. If you need an extra treatment, then that's generally one of them. So large melanomas mostly are treated by enucleation, removal of the eye, surgical removal, and sometimes radiotherapy can be used. So an example I can give you is a patient with one eye has lost vision due to another reason, macular degeneration or some other condition, and then the other eye develops a melanoma. And obviously, if it's a large one, although we would talk about enucleation to try and preserve the eye, we may try, with the agreement of the patient, obviously, one of the radiotherapy options. So plaque radiotherapy is a little disc of radiation that's sutured onto the eyeball. What we have to do is at the operation is find where the tumor is. So a light is shone into the eye, and there is the tumor, and then the plaque is sutured onto the eye. It stays on the eye for a certain number of days and hours. When the right radiation dose has been given, then the plaque is removed. And the success rates are very good. The success rates vary, depending on the tumor size and the type of plaque, between 85 and more than 95% success. So it works very well. It was invented at Barts and Moorfields in the 1920s and 30s. First ever case was done by one of my predecessors in the 1920s, who actually took a radioactive seed, radon seed, and just sutured it into the eye with a melanoma of a patient in the 20s and never took it out. So that patient remained radioactive for life. And then they decided, and they did that to children as well with retinoblastoma. And it worked very, very well. But it wasn't a very good treatment because obviously, you remained radioactive. When radon decays, it decays to lead, which is a radioactive version of lead. And so then another consultant at Barts and Moorfields invented the plaque by using a mold and using wax to put radioactive seeds onto the mold and then suture that onto the surface of the eye rather than the inside of the eye. So, and it's been developed ever since. And these are radioactive seeds. This is a plaque from America when I worked in the States. These are radioactive iodine seeds, similar to the seeds that they would use for prostate cancer, for example, but they're put onto this metal plate. This one's got a notch cut out of it so that it can get right up to the optic nerve, so you can treat very posterior tumors with it. These are what we use in the UK. These are ruthenium. Mostly in Europe, it's ruthenium that is used, which also works very well. In fact, has a lesser radiation complication profile than the iodine ones. So this is a tumor I showed you before, treated with plaque radiotherapy. Plaque radiotherapy with one of the notch plaques, and here you can see after the treatment, the tumor has regressed very nicely. The optic nerve is looking very pale because the radiation has affected the optic nerve, so this eye won't be able to see very well. Here's another one, fairly large tumor, and formed a flat scar eventually. So proton beam radiotherapy is a different way of giving radiation, also works very well. The center is at Clatterbridge, and what happens is we insert the tantalum marker clips in your local center, one of the 4 centers, and then patients travel to Clatterbridge where the delivery system is for the protons, and are treated very well there, and then the local centers follow the patients up. So with melanoma, metastasis is unfortunately possible, and as you're all aware, the main site is the liver, but also can be the lung in some situations. The imaging that is done on presentation can vary, but liver ultrasound and chest X-ray are the bare minimum. PET-CTs can be done in certain indications, if, for example, it's a larger tumor. And then screening, there's a lot of controversy about this, about which modality, how often, and so on. So I'll leave that to the medical oncologists. We used to do liver function tests initially, then we showed that that was kind of not much use. And then we switched to imaging of the liver, starting off with liver ultrasound, and then other modalities, MRIs and so on, have been used. I think using non-ionizing radiation imaging is the best, either ultrasound or MRI rather than CT scans. And mortality can be up to 50% at 5 years, depending on the size and other factors, genetics, cell type, and so on, as Sarah has already indicated. So it's a rare disorder, and there are many observational studies, and really the gold standard is trying to do a randomized trial to really get the best information. And in the 70s, there was a very strong debate amongst specialists of which is the best treatment for uveal melanoma. Should all cases be enucleated, or should all cases be treated conservatively, that is keeping the eye but using radiation? So there was a very big kind of controversial argument going on between very famous doctors. And that led to something called the Collaborative Ocular Melanoma Study, which is an example throughout the whole of medicine of how to study a rare disorder and come up with meaningful results. It was very, very expensive to do, and it took a lot of manpower and funding to do it. But the first thing it told us was to standardize the size of a melanoma. So small, medium, and large. I've put the figures there of what each one was, but the kind of the size that we quote in clinic is based on the Collaborative Ocular Melanoma Study. So the small melanoma study wasn't a trial, it was an observational study. They enrolled patients for 3 years. This was done in America, throughout US and Canada. And the aim was to record growth prospectively, because at that time the vogue was, if you had a small melanoma or a very suspicious nevus, it was not to offer immediate treatment in those days. They used to watch those before they treated. And so the results were reported in COMS 4 and 5, and I'll just take you through those. So with growth, firstly, about a third of patients had tumor growth by 5 years. 2/3 didn't have, and the risk factors were the more suspicious things. The bigger tumors tended to grow, the ones that had orange pigment, the ones that lacked features implying chronicity, so things like those white flecks, the drusen. Treatment could be anything that the doctor and the patient agreed to. So 8% had immediate treatment, a third were treated after initial observation up to the 5-year mark, and treatment could be anything. You could irradiate them, freeze them, laser them, or even remove the eye. And out of mortality, so out of the 204 patients, 6 died from the melanoma, and it was good follow-up. And really, this paper showed that the risk of melanoma-specific death with a small melanoma was actually quite small, even though nearly 2/3 of patients were not treated. And this is before the era of genetics. This is in the 80s and 90s. The medium melanoma study showed that, so it was the idea that if you kept the eye but treated with radiotherapy, does that increase your mortality? Does that increase the chance of metastatic disease? So this was a very well conducted study. Half the patients, about 660, had enucleation, and the other half had iodine plaques. Very standard treatment. And with vision loss, about a half lost significant amount of vision. But really the important thing was survival. So if you look, this is all-cause mortality. This is melanoma-specific mortality. The dotted line is enucleation. The solid line is plaque. And survival is identical pretty much. So if we can treat the eye with radiotherapy successfully, then there's no advantage to removing the eye. The large melanoma study looked at whether enucleation promoted metastasis. So this was the other idea that was wrong, it turned out, that if you remove the eye, does that increase your chance of metastatic disease? And the answer was no. They gave radiotherapy to the whole socket before removing the eye in half the patients, and in half they just removed the eye. Fairly standard treatments, and the mortality lines were very similar. So small melanomas, why treat small melanomas? Well, for a cancer doctor, it's counterintuitive to wait. So if you have a breast cancer, you don't go to the doctor and the doctor says, well, it's still small, let's just watch it for a bit. They get on and treat it. And mortality hasn't changed over the last 30 years. And obviously we all want to improve survival in this disease. And there was a study out of Scandinavia that showed that, we all know that metastasis occurs clinically about 2 years after the primary tumor is treated, and micrometastasis occurs earlier. So they calculated the size of a melanoma, if it's going to metastasize, what size it might be. And it's quite small. So everybody has shifted from treating later and watching melanomas, small ones, grow before treatment, to offering treatment earlier. So, patients will come in, they'll have maybe 4 or 5 suspicious features, and I will go through with them that, yes, we could watch it, but actually, there is an argument to treat early, and thankfully many patients are taking that up. The problem can be, though, what is a small melanoma? Is it a suspicious mole? Is it a small melanoma? Sometimes it can be indeterminate. Sometimes even experts can't agree whether this is a small melanoma or not. And then sometimes growth is used as a surrogate measure of malignancy. The other option, of course, is doing an intraocular biopsy, which has its own risks and benefits. Sarah's already touched on this, and I think I'm running a bit short of time, so I won't go into it too much, but you've seen that graph already between the monosomy 3 and disomy 3 survival curves. 8q duplication, obviously very important. With a biopsy, 2 approaches. Either you go in through the vitreous into the tumor, or from the outside, which has been beautifully showed on videos by Sarah. And for prognostication, mutation testing, targeted therapy, hopefully, I hope in the very near future, because that's what we're crying out for. Research to improve mortality. And then the issues: sampling error, seeding, bleeding, retinal detachment, sight-threatening infection, and the big deal is not having an adjuvant treatment. And there may be positive or negative psychological effects. So to summarize then, brachytherapy has equivalent survival to enucleation. There's no benefit from giving external beam radiotherapy, so generalized radiotherapy to the socket before enucleation. Small melanomas, there's no randomized trial, and the presence of having genetic testing is becoming more and more important. So if I've got time, I was going to end on conjunctival melanoma. I wasn't sure if you want me to stick to uveal or conjunctival, so... Short one? Okay, all right. So conjunctival nevus, a mole on the surface of the eye, often occurs early. You can see some examples here. Here's one that actually has turned into a melanoma. This is the same patient over several years. And obviously these get picked up more because they're on the surface of the eye. People can see them. And so they get picked up more. And that's after treatment, so we can resect them and then take them away. There's a condition called primary acquired melanosis where one eye starts to pigment, the surface of one eye, and that's a common cause of developing conjunctival melanoma. Can arise just on its own, de novo, or from a pre-existing mole. Median age is about 62, and it is usually pigmented or tan-colored. Here's a few other examples. Here's one underneath the eyelid. They can recur locally. So uveal melanoma, once it's treated, generally doesn't recur locally. Whereas conjunctival melanoma is difficult to treat because it recurs locally. Some of those patients end up with quite big surgery where we remove the eye and the entire contents of the socket, called exenteration. And these can spread not just to the liver, but to the lymph nodes as well. So the 5-year rates are for recurrence, a quarter will recur, exenteration is required in 8%, metastasis in 16%, and mortality in 7%. We stage these with a PET-CT, head and neck ultrasound. We can do sentinel lymph node biopsy. That is a particular group of lymph nodes can be sampled because this type of melanoma can travel through the lymph glands, not just through the bloodstream. And these need surveillance, mainly surgical. This is just a diagram taken from one of the Philadelphia papers on how we surgically resect these. And then we can add in chemotherapy drops, or we can use a different kind of plaque, which is just held onto the eye to give radiation to the tumor bed. So which type of melanoma has the greater metastatic potential? Well, there was this study, again from Scandinavia, looking at the difference between uveal and conjunctival melanoma. The 10-year incidence of metastatic mortality in uveal was 39%, in conjunctival was 32%. So after adjusting for the tumor size, the risk from conjunctival melanoma was actually greater than from uveal melanoma. The observations show longer survival after the primary conjunctival melanoma than the uveal melanoma, probably because the conjunctival melanomas presented a smaller size, because you can actually see them with the naked eye sitting across the table. People say, oh, what's that on your eye? And then you go and get it looked at and get it sorted. But actually, conjunctival melanoma is more likely to metastasize, probably because it recurs more frequently and because it can travel through the lymph nodes. Currently, survival periods are similar between uveal and conjunctival melanoma, but I think that's likely to change, particularly in conjunctival melanoma. It's more closer to skin melanoma, and hence some of the immunodrugs, which probably I think you're discussing this afternoon, they work better in conjunctival melanoma. So really, I wanted to talk to you about the types of ocular melanoma that we treat in our clinic, uveal melanoma and conjunctival melanoma. And thank you very much for your attention.